Today I will be presenting patient John Doe. Mr. Doe is a 23-year-old African-American male that initially presented to the emergency department on an order of protective custody. After contacting campus police saying, "The voices just won't stop talking. I'm losing my mind." John's chief complaint is, "I'm hearing things and seeing things. I just want the voices to stop." John's history of present illness includes John reporting experiencing auditory and visual hallucinations for the past 6 months. He describes hearing voices that comment on his actions and seeing shadows moving in his peripheral vision. These experiences have been distressing and have interfered with his daily functioning. Additionally, John mentions experiencing mood swings characterized by periods of elevated mood and energy, followed by periods of low mood and decreased energy. He denies any history of aggression or violence during these mood swings. John has no significant past medical history of note, denies any previous psychiatric diagnoses or treatments. He reports having a tonsillectomy at age 15 years old. He also reports his maternal uncle diagnosed with schizophrenia. He's unaware of the age at which he was diagnosed. And he also reports his mother being diagnosed with bipolar disorder at age 26. John is currently a college student and lives in on-campus housing. He denies any history of substance abuse or significant stresses in his life. Current medications include an over-the-counter multivitamin which John takes daily. No fevers or chills or unintentional weight loss is present. He reports occasional headaches but denies seizures or other neurological symptoms. He reports audio and visual hallucinations and rapid mood swings, denies symptoms of depression, anxiety, or mania. He denies chest pain, palpitations, or syncope, denies cough, dyspnea, or wheezing, denies nausea, vomiting, diarrhea, abdominal pain. He also denies joint pain or swelling, denies urinary symptoms. Physical examination. John is awake and oriented ×3. He appears at stated age and is cooperative. Vital signs are stable: blood pressure 123/74, heart rate 76, respiration 16, temperature 98.6, O2 set 100%, on room air. John is calm and cooperative. His affect is congruent with his mood. His speech is normal in rate and volume. There are brief periods of response to internal stimuli noted throughout the examination. No deformities or tenderness are noted to any of his musculoskeletal system. No rashes, lesions, or abnormalities are noted to his skin. In regards to his labs, his CBC, BMP, UA, alcohol, and drug screen are all within defined limits. His thyroid function test is also within defined limits. It's evident that John has many stresses present. Primary stresses include intrapersonal, interpersonal, and socio-cultural stresses. John's internal experiences of auditory and visual hallucinations represent an intrapersonal stressor. These hallucinations directly affect his perception, cognition, and emotional state. The distress caused by these hallucinations interferes with John's interactions with others, impacting his relationships and social functioning. Societal attitudes and stigma surrounding mental health conditions may exacerbate John's distress, influencing his perception of self and his willingness to seek help. This represents a sociocultural stressor. Auditory and visual hallucinations represent a psychological stressor as they affect John's mental and emotional well-being. And as previously stated, the stigma surrounding mental health conditions contributed to the sociocultural stressors experienced by John. There are degrees of and stresses of penetration that are evident. John's line of defenses against stress may include his coping mechanisms, social support network, and resilience. The distress caused by the hallucinations and mood swings suggests that John's line of defense may be overwhelmed to some extent, indicating a degree of stress of penetration. John reports that the hallucinations have interfered with his daily activities, indicating a sign and symptom of penetration. John also describes the hallucinations as distressing, indicating an emotional reaction to the stressor, and the hallucinations and mood swings have affected John's personal relationships and social interactions, further indicating penetration of his line of defense. Based on the evidence of John Doe, there are a few differential diagnoses are considered. First, with schizophrenia, the supporting data is the family history of schizophrenia, as well as the presence of auditory hallucinations for the past 6 months and the response to internal stimuli during the examination. The negating data, however, is the rapid cycling and mood swings. I also consider schizoaffective disorder. Supporting data includes presence of both psychotic symptoms and mood symptoms, a family history of both schizophrenia and bipolar disorder, and also the response to internal stimuli during the exam. There was no negating data present. Bipolar disorder was also considered due to the supporting data of rapid mood and cycling mood swings. Rapid and cycling mood swings, as well as a family history of bipolar disorder. Negating data was the presence of psychotic symptoms. Substance-induced psychotic disorder was also considered, however, it was easily ruled out as his toxicology screen was negative for illicit substances, and he also denied history of substance abuse. Psychotic disorder due to another medical condition was also considered as well, but John denied any seizures or other neurological symptoms, and his toxicology screen was also negative. Considering the presenting data, the most likely diagnosis for John Doe appears to be schizoaffective disorder. Some interventions based on research that can be initiated by an NP that may affect John include medication management, psychotherapy, case management, health promotion and education. Prescribing and monitoring medications to manage the symptoms of schizoaffective disorder include prescribing antipsychotics, mood stabilizers, and antidepressants. In the case of John, research supports the use of Invega, which can be prescribed PO or IM depending on John's medication adherence. Education should also be provided to John and his family regarding the purpose of these medications, potential side effects, and the importance of adherence to treatment plans. In regards to psychotherapy, the NP may provide or initiate referrals for various forms of psychotherapy, such as cognitive behavioral therapy, supportive therapy, or family therapy. These interventions are developed to help John manage symptoms, cope with stress, and improve social functioning. In regards to case management, the NP coordinates care for patients with schizoaffective disorder like John, collaborating with other healthcare providers, including social workers and community resources, to ensure comprehensive support. They may assist in John accessing necessary services such as vocational rehabilitation and financial assistance programs. Lastly, health and promotion. As an NP, education should be provided to John and his family about the nature of schizoaffective disorder, its course and strategies for self-management. Promotion. The NP may also promote healthy lifestyle behaviors such as exercise, nutrition, and sleep hygiene. In terms of the level of NP management, at the primary level, the NP may provide initial assessments, diagnose and manage schizoaffective disorders in primary care settings. They also may refer patients to specialists and for further evaluation and treatment as needed. At the secondary level, NPs may work in outpatient psychiatric clinics or mental health centers, providing ongoing management and coordination for care of patients with schizoaffective disorder, such as John. They may also collaborate with psychiatrists and other specialists to develop and implement comprehensive treatment plans. At the tertiary level, NPs may work in specialized psychiatric facilities or inpatient settings, providing intensive treatment plan management for patients with severe or treatment-resistant schizoaffective disorder. Hamrick's Role of Competencies provides a framework and understanding for the essential skills and knowledges required for the nurse practitioners to effectively fulfill the roles. Here are the competencies specified for each area of NP practice related to John's treatment plan. In regards to medication management, direct clinical practice. As a NP, we must demonstrate proficiency in prescribing appropriate medications for the treatment of schizoaffective disorder, including antipsychotics, mood stabilizers, and antidepressants. This competency involves understanding pharmacokinetics, pharmacodynamics, and potential drug interactions. Collaboration. NPs also collaborate with patients, families, and other healthcare providers to implement medication regimens tailored to individual needs and preferences. They also communicate effectively and address concerns or questions related to medication management. Leadership. NPs take a leadership role in medication management by providing education to patients and families about the purpose, benefits, and potential side effects of prescribed medications. They promote adherence to treatment plans and monitor for therapeutic response and adverse effects. Lastly, quality improvement. NPs engage in ongoing evaluation and improvement efforts related to medication management practices. They stay abreast of evidence-based guidelines and research findings to optimize patient outcomes and minimize risk. Psychotherapy, therapeutic communication. NPs demonstrate advanced communication skills to establish rapport, build trust, and facilitate therapeutic relationships with patients such as John. They employ active listening, empathy, and non-judgmental attitudes to promote effective communication. Clinical reasoning. NPs utilize clinical reasoning to assess patients' mental health needs, formulate treatment plans, and adapt psychotherapeutic interventions based on ongoing evaluation and patient feedback. Cultural competence. NPs recognize the cultural, ethical, and socio-economic diversity of patients with schizoaffective disorder. They incorporate cultural considerations into psychotherapeutic approaches and adapt interventions to align with the patient's cultural beliefs and values. Ethical practice. NPs adhere to ethical principles and professional standards in the delivery of psychotherapy, ensuring confidentiality, autonomy, and informed consent. In regards to case management, NPs act as care coordinators, advocates, resource managers, and documentators. Outcomes and goals and hypotheses for John Doe will include a reduction in psychotic symptoms, stabilization of mood symptoms, improvement in daily functioning, and enhanced coping and skills and resilience, as well as prevention relapse. Lastly, to ensure John's treatment is adequate, follow-up monitoring is required. This may include scheduling regular follow-up appointments, adjusting medications, providing psychoeducation, initiating referrals to individual or group therapies, monitoring John's engagement in such therapies, and referrals to skill training workshops or classes to focus on skill management, providing problem solving and communication skills. The NP also may connect John with community resources such as vocational rehabilitation, and collaborate with John's college or university to implement accommodations or support services to help him succeed academically. Lastly, the evaluation process. This may include the use of standardized assessment tools to monitor frequency and severity of John's psychotic symptoms and mood symptoms at regular intervals. This also may include functional assessments, and treatment adherence should be closely monitored. Lastly, a risk assessment and safety plan should be implemented, and the NP should regularly assess John's risk of self-harm or harm to others, and implement appropriate safety measures as needed. A crisis plan outlining steps to take in case of psychiatric emergency or worsening symptoms should also be developed as well. Thank you.